says on boots.
I'm going to go ahead and call to order this Employee Benefit Trust Workshop for July 14th, 2026. Let's start off with any public comments. Has anyone signed up to speak?
We have no signed up speakers.
Thank you. Tonight's presentation is informational. It's informational to the City Council, but it's also informational to the employees of the City of Kerrville, their families, and to the citizens of our community. I expect there will be some confused looks as you try to explain what we're trying to do here, but please be thorough. Please understand you're not just speaking to us, you're speaking to our entire community. All right? Let's start with Mr. Rice.
Good evening, Mayor and Council. Before we begin, I want to acknowledge that last year was challenging in more ways than one. As an organization, we know that we could have been better prepared in communicating and educating our team throughout the benefits process, and we've taken that feedback very seriously. Since then, our leadership, human resources team, and Alera, who we'll introduce here shortly, have spent countless hours reviewing options, analyzing data, and preparing for the information provided here this evening. The presentation and information will be available and sent out to all of our employees tomorrow morning, first thing tomorrow morning. Our goal is simple with this: to find the right balance between providing sustainable, competitive benefits for our employees while remaining responsible stewards of the city's financial resources. We may not have every perfect answer, but we are committed to being transparent, listening, and continually improving. And with that, Mayor, I will like to introduce Pete and Todd with the Alera Group.
Glad to have you, please.
Great, thank you, everybody. It's a pleasure to be here. I appreciate everybody having me. Again, my name is Pete Villamain. I'm a senior partner with the Alera Group. I've been in the insurance industry for 31 years and have extensive expertise in self-funding health plans, working with employers right at your size, 50 to 500 has kind of been my wheelhouse. Look forward to our discussion today. As we go through this, I am open to y'all shouting out and saying, Pete, can you please explain that again? Or we can go over that. Or if you have questions as I go through this, I'd be happy to cover those questions and answer them as we go through the presentation. Alera Group, we are the 15th largest agency in the United States, top 10 largest independent firms in the U.S. We do handle employee benefits, risk management, wealth management, as well as individual insurance solutions. So when we first started this journey of making a recommendation of what the city of Kerrville should do for the 2027 fiscal year, Dalton and his team did ask us to kind of look at some benchmark data, and we did look both nationally in the state as well as some of your peer municipalities around the state in the area. And when you start looking at what your premiums are, U.S. average, and this is looking at strictly at employee and family premiums. So if you were covering you, your spouse, and your children, across the U.S., the average premium per year is just shy of $27,000. Texas average is just north of $24,000, and Kerrville is right in line with both of those, just shy of $24,000. Because of claims experience, which we'll go into a lot more detail here in a bit, you are receiving a substantial increase from Blue Cross Blue Shield. And if we do nothing and we just take that increase, we're going to be looking at employee and family premiums on average between your three plans of $31,500. So right now, y'all's premiums are right in line with all of your peers and nationally, but the renewal is taking them quite a bit north of that. If we look at what the city's contribution is as a percentage of that total premium, and right now we're looking at employee only and then employee and family. Right now, Kerrville does pay 100% of the premium for employee only coverage on your HMO plan and your preferred plan. They pay 89% of employee only coverage on the buy-up plan. National average is 83%, so Kerrville is way ahead of what most companies are doing. On the employee and family front, national average is 75% of the premium. Depending on which plan you're looking at, Kerrville is better. On the HMO and preferred plan, right in line on the buy-up plan. If we just take the increase from Blue Cross Blue Shield at 31.7%, we are going to see a substantial increase in your premiums. Employee and family premium on the HMO plan would go up $600 a month. And this is the gross premium, $642 for the mid plan, $676 on the buy-up plan, between the preferred and the buy-up plan. So if we just take the renewal, substantial increases, something must change. Again, where Kerrville stands, if you look at the U.S. average, Texas average, South region of Texas, Kerrville currently, again, premiums right in line, renewal 16.4% higher than the majority of them. If we take the preferred medical plan, because that's the plan that the majority of the employees of the city of Kerrville are on, and you start comparing them to what other municipalities are doing, we looked at both the Kerrville Current and Kerrville Renewal, compare them against Bernie, Fredericksburg, and San Marcos. Those were cities where public data was available, and we were able to pull out that information and get a hold of that information. Current premiums are, again, some of the best ones out there. Renewal premiums would take them to almost the top of the pile. If we look at what the employee's contribution, what you pay as an employee out of your pocket or out of your paycheck on a monthly basis, and compare it against those other cities, again, Kerrville is extremely competitive. Most charge something for the employees to be on the plan. Kerrville's it's a free premium for employees. Employee and spouse premium coming out of your paycheck, Kerrville is the second lowest among your peer cities, and also among the lowest in the family premium. All right. We've looked at what other cities, municipalities, and what's happening across the country. Let's dive into your claims and why we're receiving the renewal that we are. This is called a premium versus claims report. And let's get my pointer here going, see if I can control this. This is looking at data from June 2025 through May 2026. When we look at there, Kerrville has paid Blue Cross Blue Shield, and this is both employer and employee dollars. Kerrville has paid Blue Cross Blue Shield almost $4.5 million. Blue Cross has paid out in medical claims almost $3.8 million, almost another $1.5 million in pharmaceutical claims, giving you a total claims cost of $5.2 million. If you divide total paid claims by your premium, you get a medical and pharmacy loss ratio of almost 118%. What does that mean to you? Well, Blue Cross Blue Shield has a target loss ratio of 90%. At 90%, Blue Cross is saying, we didn't make a whole bunch of money, but we also didn't lose a whole bunch of money. We're kind of breaking even there. And that's their target loss ratio. That works well for Blue Cross. It works well for the city. And when you get a target, when you hit that target loss ratio, you're looking at what we call a trend medical increase. Current medical trend, 10.4%, 8.6% pharmaceutical trend. What does that mean? What that means is what cost $5.2 million in claims over the last 12 months, if you project that out over the next 12 months, we're going to see the medical go up about 10.4% and pharmacy's claims go up about 8.6%. With the exact same claims experience, we expect to pay close to 10% more for your healthcare claims. So we start doing some back of the napkin math. And that's what we did right here. So you paid Blue Cross $4.5 million in claims, in premium. They paid out $5.2 million in claims. If we add trend to that, 10.4 for medical, 8.6 for pharmacy, we expect your claims to be next year, over the next 12 months, almost $5.8 million. Knowing that the insurance company has a 90% loss ratio, we know that that's what their target is, we ask ourselves, okay, To achieve that 90% loss ratio, what kind of premium would Blue Cross have to charge to get there? They would have to charge almost $6.4 million, which would be approximately a 43.5% increase to your premiums. When we got the renewal, it came in right in line with that, and then we negotiated them down and got them down to 32.7%. When we start looking at your large claimants and why are we spending so much in claims, Blue Cross provides us this information. We looked at your high-cost claimants from the period of October 25 through May 2026. That's 8 months of data. I took that information, divided by 8, annualized it, multiplied it by 12 to give us a 12-month projection. When you look at it, we're projecting 26 claimants with more than $50,000 in paid claims. Those 26 claimants, that's employees, that's spouses, that's children, represent 3.7% of your total enrolled employees and members. Those 26 individuals are going to represent 1.2 million in medical claims, 840,000 in prescription claims, giving a total of 2.1 million, which represents 44% of total claims paid. The other 96% are having 2 million in medical, 500,000, almost 600,000 in prescription, and 2.6 total in total paid claims. What's happening on the prescription drugs? Right now, October through May, you've paid for 6,817 prescription drugs. 90% of those were generic, 10% were name brand. That's a great ratio. Anything better than 85% generic is wonderful. Those generic drugs cost you, the members, out of your pocket $5.66 on average. For your name brand drugs, you spent out of your pocket $36 per prescription. The generic drugs cost the plan $50,000. The name brand drugs cost the plan almost $900,000. Each name brand prescription drug costs the plan $1,342. People ask, why is medical costs going up so much? This is one of the big drivers right here, is name brand medications. Top 10 non-specialty drugs. Mounjaro's at the top of the list. That's not a surprise. That shouldn't be a surprise to anybody. 112 prescriptions filled for Mounjaro, 14 members utilizing it. And don't get me wrong, if Mounjaro is a drug you need, Mounjaro is a drug you're going to get, and we're not wanting to affect that in any form or fashion. This is just more of information of what these drugs are costing and why premiums are going through the roof. That Mounjaro medication costs the plan $1,000 every time it's filled. When we look at your specialty drugs, these 72 prescriptions have cost the plan almost $600,000. Single drugs, $18,000 per script, $11,000 per script. These 12 claimants, their prescription drugs are costing almost $600,000, or a cost of $8,100 per prescription filled. So if we look at what your claims have done since October of 2020, we put together this chart. This is a rolling 12-month average of what your claims have been every month going back to October 2020 through April 26th. And it's very easy to draw a straight line right through that chart and recognize that if we don't make any changes, we can all see exactly where it's going. If we break it down per employee and per member, 300 current enrollment, 321 employees on the plan. If you count every belly button, that's including spouse, that's including every child. Total members, employees plus their dependents, 682 on the plan. If you divide that rolling 12-month claims average by the average membership over that same time period, you can see that the claims per employee per month are following that same trend, as well as the claims per member per month. So what does that mean? Well, we already got a kind of a snapshot of what the Blue Cross renewal is, but let's look at the actual numbers. I apologize, I know this is very small print, hard to read it on the screen, but if you look down here in the bottom right-hand corner, the initial renewal was 42% in this green box. Then over here circled in red or with a red box around it, we negotiated it down to a 31.7% increase. 31.7%, we know what the claims are doing. If we don't make any changes, we're going to see a big increase next year, and so everything's just pointing in the wrong direction. I know I've been giving you all a ton of information. Any questions so far? All right.
Sure.
Okay.
You have on slide 9, can you just clarify for myself or any other council member why is New Braunfels $145 for the employee and spouse? I know they're paying $15 to be part of the program, $98 for the family premium.
So those are the premiums that the employees pay out of their paycheck to be on the coverage. I do not know why New Braunfels, what their rationale and what their math is to get to those premiums, but that's just what they've worked out to what they charge their employees for their different levels of coverage.
I just saw that and I was like, man, that's
It does jump out at off the screen.
pretty low.
Yeah, it is.
Thank you.
I have a question.
Yes, sir.
So, how in the world did Kim negotiate them down so low? Why would they go?
Go down to
They're going to
31.
lose again this year based on what's there.
You know, it's hard to say. You know, they Blue Cross, and this kind of goes to the further discussion. Blue Cross has the ability to see details of what's going on. We don't have that access to that information. They know if there's a claim coming off the plan. They know if something's being resolved and is not an ongoing concern. So the full rationale of how they got from 42 down to 31.7, I couldn't tell you, but that's where they are.
I think Kim's a hell of a negotiator.
She does a good job.
Kim,
She
didn't
holds
you
our
get
feet
it?
to the fire.
Didn't you get it last year from like 45 to about the same? Didn't you?
It came down a little lower, yeah, yesterday, or last year.
Thank you for.
Yeah, so a little insight there. Blue Cross has gone through a big shakeup over the last 12 months. And we seldom see a renewal from Blue Cross below 30%. Even good running plans are getting substantial increases. So they've been, I don't remember the exact number, but they've lost billions of dollars over the last several years. All right, so we've gone through the claims. We're on to the Blue Cross renewal. So leaving everything exactly the same, not making any plan design changes, renewals coming in at 31.7%. What does that do to the employee contributions? Currently, employee only is free. That wouldn't change. But if you're covering your spouse on the HMO plan, your premiums would go up. Well, across the board, everyone's premiums would go up 31.7%. In dollars, that's another $160 for employee and spouse coverage. I'm not going to try to do that math in my head. A little bit less than $60 a month there for employee and children. $120 for employee and family. If you're on the buy-up plan, you're going to see about a $25, $23 increase on employee only, employee and spouse. You know, you can see what those increases look like. So it would be a definite hit to the pocketbook of the employees, not to mention the portion of the premium that the city is picking up, which would also be going up that same 31.7% increase. We did go out to market. We shopped the market extensively. United Healthcare is the only insurance company that came back with a fully insured quote. When we go into these quotes, there's a few terms and definitions I want you to be familiar with, because these will come up over the next couple of slides. We looked at health savings accounts with United Healthcare. Health savings account gives you opportunity to put money aside on a pre-tax basis. It grows pre-tax. It comes out pre-tax as long as you use it for qualified health care expenses. To have an HSA, it must be paired to a qualified high deductible health plan. We're also going to talk about HRA, a health reimbursement arrangement. That is an employer-funded plan. It is an unfunded liability. I like to call it self-funding with training wheels. And it allows the employer to improve an employee benefit by paying a portion of the out-of-pocket expenses for the employee. The nice thing about it is the employer owns the funds and only has to pay when there is an eligible expense incurred. So it can be an unfunded liability. They're not actually having to put the money aside for every individual. We're also going to look at United Healthcare, what they have a product called their Surest plans. These are copay-based plans. There's no deductible. Everything is paid for with a copay. And doctors are scored, and you're able to go on to their website and see what the cost will be to go to any particular doctor. Dr. Jones might be a $60 copayment, and Dr. Smith might be a $120 copayment. But you get to see that before you go to Dr. Jones or Dr. Smith and see what the cost is for their care. All right. So to get these plans, to get the United Healthcare plans to be a workable option, we replaced the HMO with an HSA plan. We replaced the preferred plan with the Surest plan, and the Buy-It plan is very similar to what you have today on the Buy-It plan with Blue Cross Blue Shield. Real quick high-level overview. The HSA plan, it is a straight deductible plan. $8,300 deductible per individual, $16,600 for the family. That's the same. Your max out-of-pocket is exactly the same. So once the deductible is met, everything is paid for by the insurance company. On an HSA plan, on a qualified high deductible health plan, everything funnels towards that deductible. You go to the doctor, you get a prescription drug, you get lab work, no matter what it is, everything funnels up to that deductible. And when that deductible is met, the insurance company kicks in and pays 100% of your claims from that point forward. There's one exception to that, and that's your preventive care. Preventive care is always covered at 100%. It's always free to go get your annual checkups, immunizations, anything that's considered wellness care is covered at 100%. So that's what the base plan would be. The HMO would be replaced with that straight deductible plan with an $8,300 deductible. Then you have the Surest plan that has no deductible, $9,000 max out of pocket, and everything is covered with the copay, ranging from $50 to $160. You need to go get a CAT scan. It's going to tell you can go get your CAT scan at these 5 different locations. Go to location A and it's $500. You go to location B and it's $1,500. And so it's going to put the power in your hands to decide, where do I want to go for my care? Do I really care? Is it really that important to go to location B if I know it's going to cost me an extra $1,000? You're welcome to go there, but it's going to cost you a little bit more. And then, of course, the Buy-It plan, the same as what you have today. We put all this in place. And instead of a 32% increase, 31.7 with Blue Cross Blue Shield, it's coming in at 23% for this plan design package. So we're getting a little bit more palatable. However, you have this high deductible health plan that has an $8,300 deductible. That's not very palatable, especially if everything is funneling up towards that deductible. So what do we do about that? Well, this is where we get creative. And we tie an HRA to it, a health reimbursement arrangement. And we do self-funding with training wheels. And the way I like to set them up is to where the employee would be responsible for the first half of the deductible, $4,150. Kerrville will pick up the next half of your deductible, another $4,150, to get you to the $8,300 deductible that United Healthcare has. So we can drive the premiums down with that high deductible health plan, and then the city can give back and share that savings with you by funding an HRA to cut your deductible in half. What's the cost of funding that HRA? It's a very low risk. We use the 80-20 rule. 80% of your claims come from 20% of your employees. We anticipate that you're going to probably spend 15 to 20% of your risk out in HRA claims. Based on current enrollment, you have the risk on your current HMO plan, currently 95 individuals enrolled, or a risk of 95 in deductibles to be met. That's a max liability of almost $400,000, assuming 20% utilizing and meeting those deductibles. I'm projecting that your claims would be about $80,000 a year on the high side in HRA claims that you'd have to tag on top of those premiums. All right, so what does that do to your employee contributions? Well, we replace the HMO with an HSA plan. Those with dependent coverage, they're going to see their premiums go up 5.9%. That's a little bit more palatable. If you're on the preferred plan and you move to that Surest plan, you're seeing a 26% increase. And then the buy-up plan, which is apples to apples to what you're doing with Blue Cross Blue Shield, it's right in line with the 31.7 that Blue Cross has. You'll be seeing that same 32% increase with United Healthcare. All right, so we've talked about Blue Cross, your renewal. We've talked about options with United Healthcare and some ways that we can make that a workable solution. We're getting ready to dive into self-funding. I want to take a quick break and see if there are any questions that we want to cover before we jump into self-funding.
I have some questions.
Yes.
So we know historically United Healthcare has a high percentage of unapproved claims. What is the percentage for Blue Cross Blue Shield?
I would have to research that and get back to you on that. I don't have that number off the top of my head.
And then on the United Healthcare, who maintains the HRA when the employee comes back for said funding? Is that city?
So no, so yeah, we wouldn't have anybody at the city cutting checks, if that's what you're asking. So we have a TPA inside our four walls that could administer those claims. And we pay those claims off of the EOB that the employee receives from the insurance company. So when they get the EOB that says that they've met $5,000 of their deductible, they can send it into our office. We cut them a check. We're going to pay it. We're going to have a zero balance account set up with the city of Kerrville to help to fund those claims off of.
And is the Surest plan, is that like an HMO, PPO?
The PPO, all of those United Healthcare plans are PPO plans.
Okay, perfect. Thank you.
You're welcome.
Kent, anything?
Do I have time for one more question?
Of course, please.
This may be coming later in the presentation, but I'm just curious about incentives for good health and rewarding employees who have gotten on a plan that perhaps doesn't require them to go to the doctor as often. I don't know.
Yeah, we're not going to be answering that question specifically or later on in the presentation, but those are definite things that we can build, whether we stay with Blue Cross or make a move to United Healthcare or go self-funding, that of creating incentives for employees to live healthier lifestyles.
Something that's always present. We're always hoping that's the case, but it's just maybe if it's a little bit more formal to implement just the verbiage of. If we could get just one person out of the 12 that's causing the, how much, $50,000 a person in that 12 group of 12 people, that's a lot.
Makes a big difference.
Yeah. Thank you.
You're welcome. All right, so exploring self-funding. Basically on a self-funded plan, you're taking, right now you send gross premium to Blue Cross Blue Shield, and what they do behind the scenes, no one really knows. But they're taking part of it and they're covering, part of it's going to administration costs. Some of it's going to pay state taxes. Some of it's going to pay claims. Some of it's going to pay prescription drugs. Insurance companies actually buy risk insurance, and so, from catastrophic losses. So they send a little bit for excess losses within their claims experience. So on a self-funded plan, what we're looking at today, we're going to be discussing, that plan, Kerrville becomes the insurance company. Now, like we just talked about on the HRA, we don't need the accounting department at Kerrville writing checks to all the doctors and hospitals. That's not a feasible solution. And so we hire a TPA, a third-party administrator, not us, an outside TPA, that's going to act as the insurance company. They're the ones that the claims will be mailed to. They're going to be the ones that pay the doctors and the hospitals off a Kerrville checking account. Kerrville can't afford the risk of unlimited liability on every employee, so we're going to cap that risk with stop-loss reinsurance. And anything that's saved, if we can be good stewards of the plan and we can put in good cost containment measures, any of the surpluses don't go to the insurance company. It stays right here inside Kerrville and can be used to help offset expenses in the future. All right, 67, just a few stats here, 67% of covered workers are covered by a self-insured plan. And if you look at self-funded plans, this is from the Kaiser Family Foundation from a 2025 study that they did. Over 5-year savings, they are regularly seeing 30 to 40% savings over a comparable fully insured plan. I can't promise you that self-funding is going to save you money next year, but I am very confident that over the long term, if we look 3, 4, 5, 10 years out, it is the right solution for long-term stability and plan costs. What do you gain? Control over every part of your healthcare spend. You know what the money is being spent on. With Blue Cross today, we get a report. Now we do get it on a monthly basis, but we do get, but the reports are very superficial, and we can't really dive deep into what's going on. We don't know who the expensive providers are. We don't know who the expensive hospitals are. All we get is overarching data. On a self-funded plan, you get detailed claims data. It's HIPAA protected. It's all scrubbed. The employee's information is not on there. None of that is being shared with the management or the team here at Kerrville. But we do have access to it at our office. And of course, the TPA definitely has access to all that information. A good example of this is we did a study. We did this on the 2025 fiscal year claims data from the city of Kerrville. And we did this after the turn of after the new year. And we looked at your top 20 prescription drugs from that 2025 fiscal year. It was a full 12 months of data. We had this analysis performed by a company called RX Valet. They are one of the vendors that we use to help us with prescription drug costs. 386 prescriptions, 3.8% of your prescriptions filled during that 12-month period. Cost the plan $1,064,000. The other 10,000 of your prescriptions cost the plan $1.4 million. Running these prescription drugs through RX Valet and looking for the lowest cost options, we're able to drive that cost down from $1.06 million down to $425,000, providing savings in claims cost of $638,000 over that 12-month period. You add trend to that, and that savings is probably north of $700,000 today. So just by changing some buying habits, we can really have a huge impact to the cost of the claims. We're not changing any of the drugs that anybody's taking. We're not turning them down and saying you can't take Humira or you can't take Enbrel or Ozempic. We're just saying, hey, what do you think about, instead of buying it here, you go over here and buy it. And maybe we can give you a financial incentive to buy it over here instead of over here. If you want to buy it here, great. Keep buying it where you are today. But we can encourage you, and it'll be a win-win for you and for the city of Kerrville if we put in some of these programs and find the lowest cost options for these drugs. So it creates opportunities that fully insured plans cannot. On a fully insured plan, we get an annual renewal. We get that annual renewal 3-4 months prior to your renewal effective date. And then we start scrambling to try to figure out what we're going to do to control those costs. We have limited claims transparency. It's a one-size-fits-all from the insurance company that they say, here, take it or leave it. They decide what cost management solutions that they're putting in place, and it's built around their overall demographics, not to the employees of Kerrville. And for us, for the city of Kerrville, and for Alera, for your insurance agents, we're having to be very reactive. On a self-funded plan, we're getting very detailed claims information. We're having monthly meetings with the TPA to go over those claims. We're looking at where the opportunities are, where is money being wasted, where can we potentially save money, and then we can be more proactive to reach out to individuals and say, hey, John, we see that you're doing this, that, and the other. Just want to know here's some other options, and if you want to take advantage of those options, we can help you out with that. We're not going to force anybody to do anything they don't want to do, but we just want to communicate and make that communication available to everyone. So, again, difference between proactive and reactive. Self-funding, very important right here at the bottom. I like this statement. Self-funding does not eliminate healthcare inflation, but it gives the city better tools to manage it. Opportunity examples, well, we already talked about the prescription drugs where we can save $600,000, $700,000 in prescription drugs. But there's centers of excellence. If you're mess up your knee and you know you have to go in for knee surgery, we can put programs in place where you say, hey, give us a call, let us know what's going on, and if you're willing to use one of our centers of excellence for that procedure, we can make financial incentives to make it, again, a win-win for both the city and for the individuals. Just some of the examples of some of the procedures that can be done through these centers of excellence: joint replacement, spine surgery, cardiac, cancer, bariatric surgery. You'd be shocked at the cost difference between CAT scans and PET scans and MRIs from one place to the other. And so we want to make sure that you have that information, and if we can communicate it to you and you're willing to use location A over location B, again, steer you in the right direction and save everybody some dollars. So what does the self-funded plan renewal options look like? Again, a lot of small numbers here on the screen. We're showing you what we feel are the best options for the city of Kerrville. We have options 1 through 4 here. The only thing that's changing on these options on this page is how much risk is the city of Kerrville taking. On option 1, the city is taking a $125,000 risk on every employee and every covered belly button on the plan. And then as you move up, it jumps from $150,000 to $175,000 to $200,000 on this far right-hand side of the screen. The insurance company based their expected claims off of the last 12 months of rolling claims data. They did not put any cost containment measures in place in their projection. It's strictly looking at what were your claims last year with Blue Cross Blue Shield, and what do they actuarially think your claims are going to be in the next 12 months if you go self-funded. And so that's where you see this $5 million in expected claims under the self-funded model. You also see $1 million in fixed costs. That's going to be your TPA, the one that's administering the claims. That's going to be renting your PPO network. That's going to be paying for your reinsurance to protect you against catastrophic losses, specific and aggregate premium. You add all that up based on your current population. Fixed costs are $1 million. expected claims without any cost containment, expected at 5 million. You add those together, we're looking at about $6 million. Your maximum claims, 6.2 million. That is taking your expected claims, multiplying it by 1.25. That's called your corridor, that 25% corridor. And if your claims go over 6.2 million, reinsurance kicks in again and pays for anything from that point forward. Now, if our claims did hit 6.2 million, whether we're self-funded or we're with Blue Cross, that would equate to a 110% loss ratio when you compare it to the renewal premium for this year from Blue Cross Blue Shield. That would result in another 22% increase next year. So we then take these numbers. Let me jump into this real quick. What would the plan design look like self-funded? Well, Kerrville is the insurance company. They can design the plan however they want. We used your current preferred plan as the starting point on the PPO plan. We have an HSA plan in there as well. But this is all just a potential plan design. It has not been vetted. We have not gone through and customized all of it and really dove deep down into it. These are all just the minutiae that we will get into if this is the route that we decide to go. And we'll work with Dalton, Kim, and their teams to custom design a plan design that's going to meet the needs of the employees of the city of Kerrville. Again, these are not in stone, but proposed monthly contributions. We'll be looking at maybe a 12% increase over the HMO plan and the preferred plan, and we would look at getting rid of the buy-up plan. Again, these decisions have not been solidified. It's just ideas and concepts that we're exploring. So, what do we expect the self-funded plan to cost us over a 5-year period? It's important to recognize that this is taken into consideration. The actuary numbers that we saw on the spreadsheet did not include any cost containment measures. Here, we're plugging in those cost containment measures. We're plugging in, and we're being conservative, that we're going to be able to save $500,000 in prescription drug claims. That we're going to be able to save 6% on your medical claims by putting in some of the tools and resources that we have to help steer people to low-cost, high-quality care. And so if you look at the green line being self-funded, we are projecting that in year 5, that the savings would be 1.6 million or 16.6% compared to a fully insured plan. And that is a conservative number. If we build it right and we manage it correctly, the delta should be greater than that. We use our internal actuary, Joe. Her name is Joe Welch. She lives out in Albuquerque, New Mexico. I spent a lot of time with her working on this. And this is the spreadsheet that she created to demonstrate that savings. And that yellow bar there, self-funding total costs. And a lot of that savings is being generated through prescription drugs and expected 6% savings on medical claims. A lot of information there. Any questions?
I do. So to achieve this savings, and in some cases, some client, an employee would need to go over here, as you said. Is that would that be a hardship possibly? I mean, that's what I don't want to happen. That's one question.
We would not force them in any form or fashion to go to one provider or another. But we do have the ability to say, hey, if you're willing to go over to this other provider, the savings is so great that we can waive your out-of-pocket expenses.
Try to keep that at least within a reasonable difference of change in miles or distance. And
correct.
Okay. The other thing I was going to ask is, what are the cities, and it might be in here, have done this, are doing it, and maybe in their year 5?
I would have to get back to you on that. But the TPA that we're working with, they have 4 different cities that they're working with, and so I could get you that information. The challenging part there is going to be able to predict what the insurance companies actually would have done compared with the same information.
Be curious just to see what they have experienced as far as savings.
Right. And we do have some of those cities as references for y'all to talk to.
Interesting.
So, you were saying a while ago that y'all could pick up the phone and call John and be like, hey, we see you doing this.
And it wouldn't be us, it wouldn't be my office, it'd be the TPA, but I'm sorry to interrupt you, sir.
So, and that's what I was gonna say, it would be the TPA doing that, because is that getting into a HIPAA situation? If they're saying, hey, we know what you're doing, or we know what's wrong with you, but if you go do it this way. And the second one, is little Johnny gets sick, the local pharmacies, or is that something that's part of this deal, so they could run down to Walgreens or Walmart or HEB or wherever and get their medication for the
Correct,
kiddos?
yeah, the majority of those savings on the prescription drugs are coming from your maintenance medications. And let's say, for instance, let's say someone has a brand new prescription for a maintenance medication. We're gonna automatically, they can go to HEB and fill that today, and there's not gonna be any problems with that. But then the TPA is going to then see that, and then they will actively reach out through their nurse case managers.
So how does it work with the HIPAA question?
So it's that they're part of the health plan. It would be just like Blue Cross calling out to them. And so that they have access to all the information, they are allowed to have that information and utilize it.
Thank you.
Councilmember Harris, also, all administration and anybody in HR has to have HIPAA compliance as well. So we do our annual HIPAA course, and we have to be in compliance with even the information that we have as well.
Have you received any feedback from local providers?
Yes, let me bring up Todd here and let's jump into that.
Okay. If I jumped
Provider-
ahead, then apologies.
I'm sorry?
Apologies if I jumped ahead.
No, you're good.
Hello, everyone. My name is Todd Peter, and I'm also a senior partner with the Alara Group. And what makes me better than Pete is the fact that I am a Kerrville resident. I've been here for 34 years, and some of you may recognize me. I ran Benefit Solutions here for 25 of those years, and then I began working with the Alara Group. And they're some of the best folks I've ever worked with. I'm very, very happy to work with them. So when it comes to network, I mean, that's obviously one of the big fears for the employees. Is, oh no, there's a change. Everybody knows Blue Cross, it's the known quantity. But as far as networks go, when you self-fund, Blue Cross Blue Shield pays a lot more to the providers than what some of the other networks do. And having that network using the exact same providers, you can save a considerable amount of money. And what we're talking about is not necessarily primary care. There may be 10% savings in your primary care, which is maybe $100,000 in savings. But when you start talking about your large hospital expenses, you're talking about saving 15-20% on those $1 million buckets. So the network could save you in that scenario based upon the claims that we reviewed. Your claims were roughly $4 million. $1 million at 2 different hospitals, and then $1 million among the providers. You're talking about significant savings that are not totally reflected in the charts and graphs that you see. The actuary basically assumed 6% savings, and I would argue that over a 2-3 year period of time, you're going to see much greater savings. But to the employees, basically our goal is we want you to be able to use the same providers you're using today. However, you get those services at a cheaper price. So we're not wanting to change basically any of the providers that you're currently going to. Same thing with the other benefits. Basically, some of those cost-saving things that we talk about, those will be optional. But over the course of time, if you're an employee and you have a big procedure that you need to do, and you have cost incentives to where maybe it costs you nothing to go to one of these providers versus your current provider, it's just an option. You know, you may love whoever it is that you're scheduled to do your procedure with. We're not trying to change that for anybody. And like I said, I live here. I'm going to see you guys in HEB and round and about, and I don't want the hate and discontent that would cause. We're doing this for a reason. We're doing it for the benefit of the employees. So we're not going to lose sight of that. what we're talking about right now is deep in the weeds, risk and financial stuff, but we're going to get down to the actual plan benefits and those kinds of things. And we're going to work the best we can to not only have benefits similar to what you have now, but hopefully make enhancements. So that's our goal. When it comes to Healthcare Highways Network, the first thing is, who is that? If you're not in the industry, you've probably not heard of them. Everybody, basically all the large insurance companies all own their own networks. So we call them the BUCAs, right? The Blue Cross, United Healthcare, Cigna, and Aetna. Humana used to be in there, but with consolidation, now that's no longer an option. But these third-party networks, a lot of smaller companies will have what we call skinny networks. So it's very limited as far as the number of providers so that they can maintain some control in pricing. That is not what we're wanting to put in here, okay? This network, basically, if you look on those numbers there, we actually looked at your actual claims over a plan year. And those actual claims, when we looked at who was in network, who was out of network, and what the situations were, nearly 97% of all visits during the 12-month report period would be in network with Healthcare Highways. That's of all your claims. A large number of your claims were completely out of state. They were emergencies or what have you. And then if you drill down, we have some of the stats, basically statewide. This network is not just limited to South Texas, to Central Texas. It's a great network all over the state. But when we looked at just Kerrville, your Kerrville visits during the 12-month report period, 97.8% of those claims would have been in network. And I actually didn't compare that to the Blue Cross numbers, but that may actually be higher than what Blue Cross was. So this network that we're looking at putting in potentially, we're not wanting to limit the number of providers that you can go to. And then for your out of network area stuff, we have some different tools that we can put in place, and one of them is reference-based pricing. It's another way to help reduce those costs. We're basically then negotiate with those providers that are out of the area to help reduce cost. So I understand this is one of the very important parts of the program. And again, you got a little insurance policy because I'm right here. And the reason I'm here is because I care about the city. I actually got in contact with Dalton after everything happened after the 4th of July to see if I could be of assistance. And I think that we have a pretty good plan in place looking for over the long term, the 3 to 5 year window. Not all cities are suitable for self-funding. Not all situations are suitable for self-funding. Your particular situation, you factor in the fact that you have Dalton who really understands this stuff. He enjoys discussing this stuff. He gets it. You have a strong management team here, and you're at the point in your trajectory where you're kind of out of options in the fully insured market of what you can do. And when you earlier you were talking about the loss ratio and how you got from a 42% to a 31%, that looks good for a 1 year time frame. However, you're starting off next year already 10% in the hole in your loss ratio. Okay, so you either pay now or you pay later. You're not going to be able to run away from the actual claims. So the process that we're looking at putting in place, self-funded, is kind of an abstract thing. But if you look under the hood of any health plan, whether it's individual, small group, large group, they all operate the same way. They all operate under this self-funded model. So we're not doing anything that's crazy. Basically what's happening is we're turning over the levers and giving you guys the options to create the plans the way you want and to control your risk over time so that you can add things, take things away, that you don't have those options with Blue Cross Blue Shield. Also, one of the things where we're talking about the RX Valet and you guys having some control over your PBM. With Blue Cross Blue Shield, all the rebates for the PBMs go back to Blue Cross. Okay? Under self-funding, you guys get those back. And someone mentioned something about why would Blue Cross, actually go down to 30%. Well, but there's all kinds of little built-in cost mechanisms and profit mechanisms for Blue Cross Blue Shield, where they're making money like on the rebates and those kinds of things. No one should feel sorry for Blue Cross. They're always making money, okay? So what we're trying to do is give you guys some more tools and latitude so that you can move around as your risk changes. When you build up your benefit trust, then that gives you more options as well to do different incentives with the employees. So did that fully answer your question?
Yes, sir. Thank you.
Hey, Todd, real quick, can you talk to what you've kind of done for boots on the ground?
Sure. Yeah. So, like I said, I live here, and I saw what happened last year, and so I've already hit the ground running as far as contacting local providers. So, one of my first calls was to Chris Ballesteros over at the hospital, and told him that one of the things we're contemplating is self-funding and using healthcare highways. And he sent me an email back saying that yes, all of the hospital services, hospice, primary care, secondary care, everybody is in network with healthcare highways, okay? Which is almost 75% of you guys' overall claims. So that that should give you guys a little bit of level of comfort. And I think the HR has that email too, so they can share that with you if you guys have questions. So that's Peterson. However, them being contracted is not sufficient, as some of the folks found out last year. You have to physically go to the practices, talk to the practice manager, and make sure they are aware that they're contracted, as well as whoever the medical assistant or the receptionist out front. So if you call somebody, and the chances of them knowing about healthcare highways is pretty low, right? So I've already kind of greased the skids a little bit and went around, and I've already been to 75% of the primary care. And all the Peterson folks, even though their boss says they're contracted, they've got to know that, and they've got to be able to communicate that to the employees. So I've already hit the ground doing that. The hospitals, I took care of Hill Country Memorial Hospital for 21 years. So I know some people over there. So that was my next phone call, is tell me about healthcare highways. Are there any issues with the network? No. And they are all contracted as well, okay? So your two primary hospitals and all the services associated with them are all in network, okay? So the kind of the next step along the way is to start hitting the specialty care offices. They're a little bit more difficult. It takes a little bit more time. But by 10/1, basically almost everybody that you guys used over the last year, I'll have personally contacted, giving them the information that includes how to verify benefits, how to follow up on claims, et cetera. And if there is any kind of an issue where there are some doctors who are cash only, there are some doctors who may have had a bad experience with HMOs, for example, so that they don't take HMOs, what have you. They all have their own experiences. But the advantage to me being here is that I can go physically talk to them. And doing this a long time, I've insured most of the doctors. So I have personal relationships with them, and so it's real easy for me to get to them. And if somebody decides not to be in the network for whatever reason, I'm going to be darkening their door to find out why, and we're gonna try to fix those things. So that's something that you guys are gonna have in place that you didn't have last year, okay? And basically, I told Dalton this is a no-fail mission, right? We're gonna make sure that there's no issues as it relates to the network. But the long and short of it is we don't want you to change who you're using. And that's why we chose this particular network over others. Okay. Any other questions?
I'm thinking. Thank you very much, though, for all the information.
Well, we'll be here. I'll turn it back over to Pete.
All right.
I'll just make a comment on it. It's, sounds like a great program, but I'm gonna look over at Kim and staff and management. We just gotta make sure that our employees are first and foremost in whatever we do. And I know that we wouldn't be sitting here talking about this and going through all this if we weren't doing that. But after the fiasco last year with Blue Cross and what happened, I don't think anybody wants to relive that again.
No, sir. And that's why we wanted to get this information out as soon as possible. We're kind of calling it the bad, the worse, and the ugly, or sorry, the bad, the worse, and the hopeful. On it, we know Blue Cross is going to be a 31.7% increase. That's a known. United Healthcare would not only be a change, but it would also be a 23% increase. What Alero has really done, and I think to the point of what happened last year, is we didn't want to just see the number. We wanted boots on the ground, and we wanted people to go into it. So coming out of this, we want our employees and our teams to get the brochures. We're going to send out some educational or informational flyers. We want them to go to their providers and start getting us feedback like they did last year. We just now have a couple weeks to be able to vet those things out. We'll get that information. We'll get it over to Todd and Alera, and then they're going to start hitting the ground running again on making sure that these specialties are going to do it. I would say the challenging part in all of this, finding that balance between the employee benefits and competitive benefits, and then, being the kind of a fiscal steward, is what do we want to do? We know there's going to be a change. Just what does that change look like? Do we feel that on the risk side, it's worth putting 31.7%, this year? So fully insured is risk on the back end, and self-insured is risk on the front end. And so we've spent countless hours really diving into this to try to see. And yes, there is risk, there is change, and we're going to continue to dive into that. And we're looking forward to getting the feedback from our teams, so we can, again, continue to do our due diligence on this. Because the only way we can get that 31.7% down on the Blue Cross Blue Shield is to take it out of employee benefit coverage or dependent benefit coverage. That's about the only thing we can do.
Now, notice we have about twice the number of employees, family members that are also insured. So, like the gentleman said, and like Delane said and everybody else, we're going to start 10% in the hole for next year if we go this direction. It's just, we got to take care of our own, but we also have to look out for ourselves as well. And, if we have to go risk in the front and it makes sense, I do also want to say thank you, because I know you sent out an email to all city employees about watching this, so they can hopefully get a little bit of pre-information before it's presented to them. But it's, I'll speak for myself, but it's just, I know that I want to make sure that our employees are taken care of first and foremost, as well as our pocketbook. So.
And I'll just add to that to say, if I had insurance, I was an employee and had insurance through the city, if you explained it to me in a way that said, this is our goal eventually, to get to this point where your premiums may go down. And so it's really, because I'm looking at this, what we're saving page, and going, yeah, it's like anything else. You move into a home or anything else, you have that initial cost to get in and get it insured and get it drivable. But then eventually it's paid off and you have an investment, whether it's a house. So I just look at it as if this was me, and I would say either way I'm going to pay more, number one. But number two, is there a way we can do it where eventually we don't? So I kind of think it's become clearer and clearer as I read through all of this, and I'm sure it'll take a little bit of a process, but anything we can do to help get that message, because I think I like it. You're hired.
Yeah, one thing too, and Pete kind of spoke to it a little bit on the plan design, and I want to make sure we reiterate. We wanted to compare apples to apples, which is why we just took the current deductibles, out of pockets, and just applied an HSA to it. We can build that plan however we want. And when we say we can get into the granular level, we can get into the granular level. We can even as so far as basically determine what premiums increases the employees can have. We put 12% on there just to set realistic expectations and have a conservative approach. But it gives us some flexibility and some opportunity where right now our EBT trust, or our employee benefit trust, has been dwindling. This is an opportunity for us to, over time, start building that employee trust back, benefit trust back up, where we can then mitigate some liability or some risk by having cash in there. So on the years that were surplused, we can put it back. On the years that were not, we take in, and over time, we build that up to do it. So practical or operational, that's what we're kind of looking at is how do we build the EBT back up so we can absorb some risk in there. Over time, we can ideally increase the per employee risk from 125 to say 200, and now your administrative costs go down because we're assuming a little bit more risk because we can. And so diving into that, looking at the over 50,000, employees, and then you cap it with stop loss. So there's a lot of flexibility, and each year as we get better at this, we can bid out each individual component. If we don't like our PBM, our pharmacy benefit manager, we can bid that out. We can bid out our TPA. We can negotiate with the third-party administrators.
Control, yeah.
We have a lot more control over every aspect of this plan, all the way down to the details. And to your point of incentives, even we can still apply those incentives. We can still do HSA, programs. So we are looking at different incentives to give back, because if you're an employee only, well, you're saving the city a lot of money, technically speaking. And so we want to find ways to give back, to the employees that are doing that. So all of these things we're going to be diving into over the next few weeks.
Kind of gives them ownership in a way.
It
I mean,
does.
it's like we're all in this together, and we're not at the, control of a company that's making money off of us, basically.
Thank you. Mr. McKinney? Anything?
So the United States has got maybe the best health care in the world, but the payment system is a screwed up mess. So we're kind of cutting out some of the fluff, because I know, gosh, if you go pay cash at the hospital, you get a lot better deal than what the insurance company's paying. I mean, there's all kinds of crazy things that go on in the background that I don't even begin to understand. And but the drug thing is, if you can get a better source for the drugs, and you're saving, that's a huge amount of money that can be saved. And so I think if the employees cooperate and look at, take some options that they're offered that get some services or drugs other places, it'll save them money, and it'll save the city money too. So it sounds like, anyway, the insurance companies it's so opaque and about what's going on in the background. I think it's good what Dalton was saying, that, okay, we can, we can negotiate some of these different parts of the plan, and that certainly seems like it could make some savings for all of us.
Yes, sir. And some companies, I will just say some organizations, don't even allow or authorize GLP-1s or, Mounjaro or Ozempic or some of these drugs. They don't even allow them. There's some local organizations that don't even allow them on the plan, where if you want to get them, you have to pay cash. So it's very, and to that point is we want to minimize those changes. We know change is big. We know there's going to be a lot of changes to this. Really, the employee is going to see, the goal is the employee to see less. There's always going to be, hurdles that we're going to face in, the first year, first couple years. But the goal is to minimize those changes, where the city can absorb a little bit of risk, a little bit of liability, and we're able to be able to give back to our employee in that regard.
Smith?
I just want to say thank you for putting a great presentation together that is understandable. And this is obviously a national issue. While you provided Kerrville numbers, this is obviously a national issue that anyone who's in here or watching this online can then take this to wherever they live and understand why everything is going up. So thank you for your time in explaining it to where majority of everyone can understand. So thank you. Thank you, Dalton, and your team for all your work on this as well.
Ma'am.
Pete, Todd, any closing words?
No, we just appreciate the time. Todd's office is literally just right around the corner from here. He's going to be that first line of defense for the employees. I can't, Dalton just alluded to it. We can't promise that there aren't going to be some bumps in the road, but we're here. We have a local presence. I live just 30, 45 minutes down the road, and I can be up here at any time as well. And we just appreciate the opportunity to present this to you and look forward to helping y'all out however y'all decide to move forward over the next 12 months.
Any closing words, Dalton?
Yes, sir. We appreciate y'all taking the information. We know it's a lot of information. We wanted to get y'all kind of, we'll say, 100,000-foot view of the state of healthcare, which obviously it's a little bit grim nationwide. And again, how do we find that balance?
Is this presentation going to be emailed tomorrow to employees?
Yes, sir.
Or some semblance of it?
Yes, sir. It'll be the exact same presentation with a couple informational flyers, just kind of talking about healthcare highways.
Be made available to the public as well?
Absolutely, yes.
And the press?
Yes.
All right, if we have nothing else on the agenda, I'm willing to close this Employee Benefit Trust Workshop. Closed at 5:12 p.m. Thank you.